Welcome to tonight's Aspiring Women, presented by Aspirus Riverview Hospital. The topic today is conquering cholesterol. Diet and nutrition play a major role in conquering cholesterol by the foods we eat. The emphasis has always been on the type of fat we eat versus the cholesterol we eat. So if you're looking at food labels, it's important that you check the fat content and the types of fat you're eating more so than the cholesterol content. Most recently, there's been some research that is now pointing to the sugars we eat as being also important. So the research on nutrition and how it plays a role in different diseases is evolving. The bottom line is eat a good variety of foods, eat enough to meet your needs, don't overeat. For heart health, focus on a plant-based diet and get those essential fatty acids and omega-3 fatty acids from the food we eat. Tonight, the refreshments are going to represent those factors. The first item that we're offering tonight is the Greek salad kebabs. The Greek salad kebabs consist of olives, which is an important source of a monosaturated fat. We've all heard that we should be using olive oil. Well, olives provide that essential oil also. Coupled with the colorful vegetables and the healthy yogurt, you've got a low-calorie appetizer that is good to eat and easy to make. The next appetizer tonight is our salmon mousse tartlets. The salmon in this appetizer provides essential fatty acids in the form of omega-3s. Omega-3 supplements are pretty common, but it is best to try to get those from the foods that we eat. This tartlet not only provides that omega-3 fatty acid, but has the added bonus of 4 grams of protein per tartlet. And our dessert, rhubarb strawberry crisp. What is not better than fresh rhubarb, fresh strawberries with an oatmeal-based crisp? All those items are heart healthy. It's a dessert that's in season this time of the year, and you can find recipes as well as this recipe to enjoy. Hope you enjoy tonight's presentation on conquering cholesterol.
So welcome to our Aspirus Aspiring Women presentation on conquering your cholesterol. This evening, hello, I should introduce myself, shouldn't I? I mean, I'm wearing a name tag and most of you know me, but my name is Nan Taylor and I work for Aspirus Riverview Hospital and Clinics, and I am so glad that you could join us tonight for our Girls' Night Out. This evening, our agenda will include our aspiring a cappella group, yay. Of course, our presentation, a question and answer period, some door prizes. What would this event be without a few door prizes? And then at the end, as always, we will have an aspiring women gift for you. So we're going to start our evening tonight with another fabulous presentation by our Aspirus a cappella group, or aspiring a cappella group, excuse me. Please pay close attention because they will not be able to give us an encore presentation this evening. Also, I want you to know that I want to thank these ladies for giving up their free time to create and practice these songs. So they take these songs and they come up with the words and they come up with the harmony. And so first off, we're going to go from left to right, is Peggy King. Oh, come this way, come this way. Peggy King, who is waving, she is the executive assistant to the CEO, and she is singing tenor this evening. And then next to Peggy, we have Cindy Orzel. And Cindy is our HR partner, and she is singing baritone. Next to Cindy is Kathleen Orminski, who is the director of our emergency room, and she is singing bass. And then our lead is Rhonda Alp, who is the administrative assistant to the VP of Quality. So ladies, please take it away.
Doo-doo-doo down, doo-doo-doo down, down, come-a down, doo-doo-doo down, down, come-a down, doo-doo-doo down, down, cholesterol cholesterol is hard on you. Don't take fried food away from me. That would leave me in such misery. Doctor, tell me what to do. Cholesterol is hard on you. Remember when we used to eat lots of fatty foods and red meat. Think of how my arteries feel. The complications, they are real. They say cholesterol is hard on you. Now I know that is true. Don't say that this is the end. Instead of clogging up, I wish my arteries were free again. I beg of you to fix me, please. I don't want to have heart disease. I just want to start anew. Cholesterol is hard on you. Doobie-doo down, 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 coma, down, doobie-doo down, 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 coma, down, doobie-doo down, down, down. Cholesterol is hard on you. Doobie-doo down, down.
Truly, I can't thank these ladies enough. This is what they do in their free time, is practice these songs. So we'll start the presentation shortly, but first I'd like to share just a few words with you. I don't know if you know this, but nearly 1 out of 3 deaths in the U.S. is caused by heart disease and stroke. At least 100,000 of these deaths could have been prevented through changes in our own health habits, such as stopping smoking, increasing our physical activity, and eating healthier. Let me repeat that fact. 200,000 deaths could be prevented by us changing our own habits. That fact stopped me short, actually. Why? Because 2 months ago, my brother suffered a major stroke. There's no family history of strokes, and my brother is a relatively young man. However, my brother smoked, was not careful with his diet, and did not exercise. He is now working hard to recover his speech and the use of his right arm. I share this with you because over the months, all of you aspiring women, each and every one of you, have become an extended family to me. I see you at the Y, I see you at the grocery store, and all kinds of other places. I'm going to ask you to pay close attention to the presentation this evening. Together, let's pledge to make healthier choices so we do not become one of those 200,000. And now I am so very pleased to introduce Dr. Melinda Roskos, who is presenting at an Aspiring Women event for the very first time. Don't scare her, ladies. Dr. Roskos has both a medical degree as well as a PhD in immunology, which means she went to school for a very long time. She graduated from Georgetown University School of Medicine and then did an internship and residency at the University of Texas Southwestern and a subsequent fellowship at the University of Texas Health Center. She has also contributed to 12 articles in 12 medical journals. She is board certified in both cardiovascular disease and internal medicine. So now let's get to the fun stuff. Dr. Roskos was born in La Crosse. She lived there for 6 months. Her father was doing his residency there. Her father is also a physician and just retired from his practice, I understand, and was a pediatric oncologist hematologist. So I don't think there's any shortage of brains in this family. Dr. Roskos owns 2 dogs, very important to me. I love to know that people own dogs. They're Mia and Dante, and she rescued them from an animal shelter in South Florida. As you can imagine, she is a very busy woman, but hopes someday to have time to travel. I've only really had the opportunity to meet Dr. Roskos once and was immediately impressed by both her warmth and her intelligence. We are so fortunate to have her here with us tonight, so please give her a warm welcome.
I'm kind of soft-spoken. Can everyone hear me? Yeah, is that okay? All right. Well, thank you so much for inviting me to talk to you guys tonight on a topic I love, cholesterol and heart disease, in a demographic that I think is really important in women. So unfortunately, heart disease is the #1 killer of women, so I think we just need to be more aware of it and make sure we take care of ourselves and not just our families. So, okay. So we're going to talk tonight. Let's see here. Okay, I have some objectives, like our mission tonight, ladies, which we're going to accomplish. We're going to talk about what is cholesterol. What are we talking about when we talk about lowering cholesterol, bad cholesterol, good cholesterol? We're going to talk about how it actually causes diseases like heart attacks and strokes. And then what you can do to improve your cholesterol and hopefully improve your heart health for the long term. Okay. So cholesterol is actually something that we all need. It's a waxy substance that's found in your bloodstream in your bodies, and it's important for things like your nerves so that you can conduct electricity and have nerve impulses. It's produced in your liver, and it's important for various functions. But when it collects and you get too much of it in your body, then you can start having problems. So we consider there to be three major types of cholesterol, all right? And you might have heard of some of these. You have your HDL, your high density lipoprotein, and that's the good cholesterol. That's the kind of cholesterol we find that the more you have, the more maybe heart protective it can be considered. And women tend to actually have a little bit more in general than men do. You have LDL, the low density lipoprotein, and that's the bad cholesterol. And that's what we get focused on. We want to bring those numbers down, and what we get worried about causing heart attacks and strokes. And then you have triglycerides. And these are kind of like, they've been in the shadows in the past, and we're learning more and more that having too much triglycerides can also cause heart problems. So the good, the bad, and the ugly. So HDL, LDL, and triglycerides. Those are the three major ones that you're going to look at when you see your lab results. Okay? And so this is just a cute little picture. You have little HDL, good stuff, LDL, bad stuff, and then your triglycerides. Okay? And they add up to give you your total cholesterol when you get your lab results. So if your cholesterol is like around 200, it's the summation of these 3 different types of cholesterol. So why is cholesterol a problem? Well, when you have too much of it, it can clump together to form plaques. All right, so you may have heard that term, plaquing, and that can happen. And so this is a picture, like a cross section of your blood vessel. Okay, and this red stuff here is normal blood that should be swishing through, going to your heart and your kidneys and your brain. And over time, the cholesterol with other stuff in your blood, like calcium, can clump together and form a plaque. And then as that plaque builds up, the lumen, the inside of the blood vessel, gets smaller and smaller. And that can become a problem. Okay. So this is just another picture of how that can happen over time, where you have the bad cholesterol kind of clinging here to the side of the blood vessel wall. And you can see that it becomes more difficult for the blood to move through. And actually, these like little plaques become also, they can become unstable, meaning that they're like a scab like on your knee. They can be a scab like that in your blood vessel. And so over time, if, depending if your blood pressure is high or if you're maybe a little anemic, the blood flows a little faster, these plaques can kind of break off. So some of that cholesterol can kind of travel down, and the plaque underneath the soft tissue can become, your blood vessel sees it, and it can be thought of as like another scab or another, like an injury, like you cut yourself. So your body's going to jump on that, clump around that blood vessel where it's broken off and form a big clot, a big thrombus. And that's actually one way that you can have heart attacks or you can have strokes. And that's what cholesterol medicine is good for. And we'll talk a little bit more about that later. So this process here that I'm describing is called atherosclerosis. So if you've heard the term atherosclerosis or atherosclerotic disease, that's the big general term for any time you have cholesterol plaquing in your body. And that can apply to in your carotids or your brain, which might give you a stroke. It can happen in your heart. It can give you heart attacks. It can happen in your belly or in your legs and give you what we call peripheral vascular disease, where you have problems with your leg pains when you walk. So go over a little bit more detail again, so just keep hearing this and hopefully remember some of these points. That plaque is made up of fat, calcium, cholesterol, and other substances. Okay? So what happens is when you have that extra cholesterol, like the extra LDL, the bad stuff, or the triglycerides floating around in your body, it clumps together with calcium and fat, and it makes those plaques that go against the blood vessel wall. Okay? And actually, maybe you've had a chest x-ray before or a CT scan where they do x-ray imaging of your body. And when you have a lot of cholesterol plaques, you can actually see that on chest x-rays and CT scans because the calcium in the plaque shows up. And so if you have a lot of very high cholesterol and bad cholesterol disease and you have a chest x-ray, you can actually see the big blood vessel coming out of your heart and follow it down because of all that plaquing. That's not a chest x-ray you want because that means you have a lot of cholesterol and it's starting to add up in your body. Okay. So as the cholesterol builds up and the plaques form, you can narrow the lumen, the inside of the blood vessel. So it takes, you're not getting as much blood to various parts of your body. So that might not be enough blood to the heart muscle. It might not be enough blood to your brain for a stroke. And when that happens, you can end up having, we call it an infarction or a blockage. And if you have an infarction in your heart, you're having a heart attack. If you have an infarction in your brain, you're having a stroke. And that's why we get really concerned with cholesterol and cholesterol plaques. Okay, and also the other thing that cholesterol can do, as I was saying before, is not only does it just make the lumen narrower, narrower, narrower. It's like that, like in your garden hose, as you have a lot of sediment or buildup deposits in the garden hose, and it just gets narrower and narrower. You can also get the deposit to break off, and that's when you can form again a new blood thrombus, a new collection of blood and platelets and all these other cells that try to stop you from bleeding inside. It will block up the lumen and give you a stroke or a heart attack that way. So 2 ways that kind of cholesterol can add up to hurt you or affect your health. That's what we want to try to prevent. So when the plaque happens in your heart blood vessels, it's called coronary artery disease. Okay, so this is kind of when people start using the term heart attack, this is most likely what they're talking about. So you have 3 big blood vessels in your heart, all right, and they branch off and they go to 3 large parts of your heart. And when you have a blockage in one of those, that's when you can have the chest pain and you start, have a heart attack. And we can go in and we can do procedures like a cardiac catheterization. You may have heard that term, or cardiac cath, where you can actually see the blockage in one of these 3 big blood vessels in your heart, and we can actually open it up. We can either suck out the thrombus. We have neat little tools that will go into the big blood vessels and remove it. Or we can, if it's like a real big piece of that cholesterol plaque, we have something called a rotor-rooter, which actually goes through and kind of you root through the plaque and you open it up. And then we put stents in. And these are little tiny devices that kind of collapse down and they fit through your blood vessels. They get to your heart and we open them up and then it lets the blood through. Okay? So that's what's happening when we say coronary artery disease. What we found recently is that there's also something called coronary microvascular disease. So what does that mean? Well, you have these 3 big blood vessels. So it's kind of like, think of one of them like the Mississippi River or like the Missouri River, giving blood to huge parts of the country. Well, out of the big rivers, there's come little rivers, and then little tributaries, and then little creeks. What we found is that you can have cholesterol in the big rivers, but you can also have cholesterol in the little rivers, these little tributaries. And when that happens, you can still have chest pain, and you can get chest discomfort. but you can't unfortunately open it up. It's more difficult to treat with these interventions like the cardiac catheterization or stenting, or even when you have like an open heart surgery and you do bypass grafts, if you've heard of that. So fortunately, for women, what we find is that a lot of women end up having this more microvascular disease. So the big blood vessels are okay, are open enough to give blood, but the tinier blood vessels have the cholesterol, have the blockage, and they're not getting as much blood as they should. And then people can end up having this kind of chronic angina or chronic chest pain when they have, they're working out or with activity, or if they're really with a lot of emotional stress, if they're really angry or really excited. And that can cause some of that chest discomfort. And so, again, we're finding that more and more women are more likely to have this than men are. So something kind of unique to us. Now, when you get plaques in your carotids here, those are the big blood vessels in your neck. That's how people can get strokes. So the blood vessels can actually just totally occlude, so you're just missing blood from one side of your neck up to your brain, and that can give you a stroke. Or if that cholesterol, because it actually, there's a Y, how the anatomy works, there's a little a division. Sometimes that cholesterol can actually break off. And that, when the cholesterol travels through your brain, it goes until it gets lodged, and that also gives you a stroke. And it turns out that when you look at numbers and demographics and what causes disease in men versus women, women are more likely to have strokes than men. And so when you start including strokes as an atherosclerotic disease, as a cholesterol plaque disease, this is where unfortunately a lot of women can suffer from. That's why we have to pay attention to things like cholesterol and maybe aspirins to keep the blood a little bit thinner. Okay. And then peripheral artery disease is when you get plaques in the big blood vessel in your belly or into your legs. And so this one actually you'll see a lot of times in smokers. For some reason, the nicotine and all the bad stuff in the cigarettes will affect your legs more, and so you end up getting more cholesterol buildup there, and the blood vessels just get smaller and smaller. And so you get what we call claudication, or like a walking pain. So when you walk, after like a certain, say 2 blocks, you start getting cramping or pain in your legs. And that can be because you're getting blockages there. And because of that too, if you have other problems, like say you have diabetes, where you're more prone to infections, or it affects your nerves so you can't feel the bottom of your feet when you walk on the piece of glass that you didn't notice about because you lost the feeling in your feet. You also don't have enough blood to give all those good, like your white blood cells, the cells that fight infection, down there to be able to recover from that. So that's another reason why we worry about cholesterol, and we don't like people to smoke. All right? Okay. So I think we learned a few of these kind of staggering, not so happy facts that 1 in 4 deaths in the United States can be related to heart disease. And unfortunately, heart disease is considered to be the #1 killer of women in the United States. And someone in the United States has a heart attack every 43 seconds. And people with higher cholesterol are more likely to have heart disease and to suffer from this. So also, I guess, I don't know, good or bad, about 5% of the population has a genetic tendency towards heart disease. And what this means is that there's about 5% of the population that for whatever reason are born with the genetics to have a lot of extra cholesterol, okay? This is like a familial hyperlipidemia where for whatever reason their body just kicks it into high gear to make a lot of cholesterol, especially a lot of that bad cholesterol, the LDL. And you can actually see that sometimes on their body. Like you can get, they're kind of white or yellow pearly cholesterol deposits. And you might notice them like around your eyes or your elbows or like on the back of your heels. And they have so much cholesterol going through their body that it starts depositing in their skin. So that's when we say that 5% of the population are at risk for that. Then 95%, the rest of us that don't have that, our risk for heart disease comes from stuff that we have a little bit more control over. Okay? It has to do with our diet. What are we eating? How much exercise are we getting? Do we smoke? Is our blood pressure controlled? Is our diabetes controlled? Some of it we can't control. Things like, if you're a guy, you're more likely to have heart disease, like heart attacks earlier on. Women actually we find are relatively protected up until menopause. We think that the estrogen and progesterone help protect your heart. And what we find is that once women hit menopause, around 55, they actually quickly catch up with men in terms of their risk of heart disease. The other staggering fact is that for the long time, actually it was in the 1990s, that they realized that women have heart disease. Like, it's not just a men's disease, it's a women's disease. And they realized that women were actually very underdiagnosed and undertreated because women tend to present different than men. Women don't usually come in and say, I have an elephant sitting on my chest that's going down my left arm and I'm sweaty and I think I'm going to throw up. When they have heart disease and they have heart attacks, they feel more short of breath. I feel a little nauseous. I don't feel really right. I'm tired. I can't do things around the house like I used to. Like, those are the symptoms of the complaints that most women present with when they're having heart disease. And that sounds very non-specific. And so for a long time, that was just like, well, you're a woman, you can't have heart disease, and it was ignored. And we're realizing now that women do have heart disease, but it's just the presentation's going to be a little bit different. And so things like, my energy level's down, I'm more short of breath, I just don't feel right, I have like this weird feeling in my belly. Those can all be signs of heart disease, and especially when you have the right risk factors, we really, I think as a medical community, we're taking that much more seriously, and we're trying to recognize and diagnose and treat women earlier in their disease process. So, all right, so these are some risk factors for heart disease. These are things that we consider put you at more risk than others for developing heart disease. These include having high cholesterol, and that's really going to be the LDL is what we look at as one measure, as well as that's the bad cholesterol. We also look at the HDL, the good cholesterol, and again, we're learning more and more that abnormal triglycerides, elevated triglycerides, also are not a good thing for your overall heart health. Being overweight or obese, not maintaining a good body weight, not exercising. These are all things that can contribute to having increased risk of building up of cholesterol and atherosclerosis, strokes, and heart attacks. High blood pressure, diabetes, people with chronic kidney disease, smoking, and then just a family history. So some of this, you can control, how much activity you have, the kinds of food choices you make, you have control over. Some things like diabetes or high blood pressure, that might be more familial, but you can control how well those disease processes are controlled in you. So making sure your blood sugar is right, going to the doctor, like as you're scheduled, making sure you're taking your blood pressure medication. That's all stuff that we have, as we all have control over that. So again, reiterating the fact that this, we have control over it. We don't all have to be the fat cat here. So we can stop smoking. Just do 30 minutes of good exercise a day for at least 5 days a week, and that's like they say moderate intensity, and that's kind of like you're walking, you're biking, you're working in the garden, you're doing yard work, something that kind of just makes you break a sweat. So if you broke a sweat, you probably are getting at least moderate intensity exercise. All right. And then we talked about blood pressure and diabetes control. So these are things that you can't control no matter what you do. So if you're a guy or a girl, you have no control over that, unless you're in Hollywood. Or if you're a man or your age. So as you get older, you're more likely to have heart disease. And again, we think with women, we see this, that after they reach menopause, they catch up with men in terms of their risk of heart disease. And then family history. So we pay special attention when people when they say family members have had heart disease earlier in life than not. So that's earlier than 55 for men and earlier than 65 for women. Okay. All right. So what are some ways that we can kind of control our cholesterol and keep ourselves healthy? So one is know your cholesterol. We can get that checked, and that's actually a guideline that is routinely followed. Next is looking at lifestyle choices. Are we eating good foods? Are we making good food choices? Are we getting some exercise? And have we stopped smoking? And then sometimes we just need medications because no matter what we do, we just need some help. So, all right. So the cholesterol, I think, I'm sure a lot of people have had that done in this room. And what you do is it's that fasting cholesterol. So you're going to not eat anything the night before. You go in and then they check it in the morning. And so people that don't have any known heart disease, we check every 5 years, usually beginning around age 20. All right. So once you have more risk factors, we know your cholesterol is high, your HDL, the good cholesterol is low, or you're a little bit older, you have heart disease, then we tend to check this a little bit more. We're more aggressive with the numbers. So what are some normal numbers? So yes, total cholesterol, above 200, we get concerned. We look at the LDL, that's the bad cholesterol. And ideally, we'd like it under 100. Over 190 is a problem. So the American College of Cardiology and the American Heart Association often provide guidelines to help physicians treat high cholesterol. And in the past, they've focused more on numbers for the LDL, depending on what your risk factors were. Have you had a heart attack before? Have you had diabetes before? They may say, well, we want your LDL below 70 ideally, or at least under 100. And then for people that don't have those risk factors, there were certain numbers. That's actually changed in the last 3 years or so. And so now we find that there's kind of 4 broad groups of people. And basically, if you fall into those groups, you just want your cholesterol as low as you can go. So you get the LDL as low as possible. And again, there's more and more clinical trials coming out saying that even getting your triglycerides down are important. Those 4 groups of people that we pay more attention to. Have you people that have had a heart attack in the past, or stroke or peripheral artery disease, something that means that you have cholesterol plaques in your body and you've been affected by it. People that have diabetes, because that's considered something equivalent to having heart disease. People that have an LDL, the bad cholesterol of 190, is another one. And then there's a risk factor, and I'll go through a calculator, a way to estimate from the general population what your risk is. And people that have a risk of 7.5% should also be on cholesterol medication. So that's how we're approaching it these days. And then LDL, HDL, the good cholesterol, we don't like it below 40. Above 60 is great. That's protective. And then triglycerides, under 150 is good, where you should be. Over 500 is a problem. And we're finding more and more that this range, 150 to 200 is also an issue. So usually, actually, as an interesting aside, when you have your triglycerides get this high, 500, 1,000, what you end up, you're actually at risk for having things like even pancreatitis. You can have cholesterol, heart disease problems. So people with really high triglycerides usually present. It can be in a number of ways. So, okay. All right. Okay, so. All right, so one way to lower your cholesterol, and this is the way that we generally like to start out with, is just change your lifestyle. And that's actually, it's probably the most effective way to lower your cholesterol. There's several clinical trials that are a little bit older, but have basically shown that if you eat well and you exercise, that is the most heart protective thing that you can do. It's a really hard thing to do, because what we're asking you to do is oftentimes is changing your lifestyle. I mean, what you eat, how you eat, who you eat with, how much exercise you get, that's all just very inherent in your lifestyle. And so to change that, it's like you have to consciously think and reprogram yourself almost to accomplish those things. And that's a lot. So very easily said, but to really achieve is a big deal. It's a challenge. But things that you're going to look at, making sure that you're making good heart healthy choices. So that's when you have to choose what meat you're going to prepare for dinner. More chicken or fish and less of the red meats. You want to be able to bake it or broil it or grill it and not fry it. You want more fruits and vegetables, less of that the meat and the potatoes, less potatoes, pasta, and rice. Kind of limit those. Dairy products, low fat or non-fat dairy products are good. And it's just making those kind of choices. Getting physical activity, getting out there, for 30 minutes a day, getting your heart rate up so that you're sweating. that can be really challenging when, especially, like a lot of women, there's so much on your plate, you're trying to, get here and there and take care of so many people. To be able to fit that time in for yourself, to look out for your health can be really hard. And then, quit smoking, which is, I think, everyone knows. All right, and so when you're making choices about the kinds of foods you want to eat, it's important to start looking at the labels on the foods, at the grocery store and such. And so the good foods are going to have more of the, look for the unsaturated fats. So whether that's monounsaturated fats or polyunsaturated fats. Those are things like olive oil, canola oil, peanut oil, sunflower oil. They tend to be liquids at room temperature, probably not butter. And then polyunsaturated fats are more like the kinds of fats you'll find in vegetables or fish. Things to avoid, probably if it tastes good. So you have saturated fats and transsaturated fats. And the transsaturated fats were the things that like cities were trying to outlaw a few years ago. And that's going to be stuff that's found in your processed foods. So like, I don't know, you go to the grocery store and you buy yourself a cake or you buy cookies there. You go to McDonald's or out to eat. A lot of those foods are going to be high in that trans fat, and that stuff, that's what you do want to avoid. And then the saturated fats are going to be your red meats or your the full fat dairy products. All right, and so this is one of a common label that you would see on a box of food. And what you're going to look for is under the total fat, looking for your trans fat and your saturated fat. Okay, so you won't usually find the huge red arrow here, but this is, again, looking at that and trying to limit how much is in there. So having, just a little bit of fat, you may be thinking that you're okay, but it's if you have a lot of the trans fat, that's not helping you. Okay. So then again, just to reiterate, the good oils are olive oil, canola oil, sunflower oil, peanut oil. Again, because they're the unsaturated, the monounsaturated fats. Okay. And then fiber can also help because it clumps to fat, and then it just eliminated it through your system. So that's we recommend a high fiber, and that's why like Cheerios and stuff can advertise that they're good for your heart because they have more fiber and they just help move it along. So okay, so this is in your packet, I know. It's just a summary of what's good and what's bad. So what's good? Lean cuts of meat, low-fat dairy, egg whites. The good fats are going to be like your olive oil, your fish oil, your coconut butter. You can do whole grain flours, breads, pastas, brown rice, and then fresh fruits and vegetables. Okay, and then again, exercise, moving around, physical activity, that's what's good. And whether that's walking, that's biking, that's going into the pool, yoga, Pilates, yard work. I mean, honestly, if you're really scrubbing your floor, that counts. You're breaking up, you're getting a sweat doing that. But those are the kinds of things that are really going to help prevent or protect your heart. And then this is, just a little bit on the types of physical activity. So you can have aerobic activity, and that's the stuff that's going to get your heart pumping and a little bit make your heart stronger. So that's, again, walking, running, biking. Then you have strength training, and that's just, the stretching kind of exercises, and as well as flexibility, where you work and those are important. But again, you do want to get your heart rate up, and that's what's going to protect the muscle. Okay. And then this is there's these various calculators, and I don't think this is in your pamphlet, but with the new guidelines I was mentioning about your cholesterol coming up, they have these atherosclerotic cardiovascular disease risk estimators. And so what it does is it can calculate your 10-year and your lifelong risk of having heart disease. And we can use this as a tool to decide, do you need to be on cholesterol medication or not? And so these calculators are available online. If you just Google ACDRE, you'll come up with them. This is from the NIH website. The American College of Cardiology has one. I mean, there's various types. But they're going to ask you, are you a man or a woman, how old you are, what your total cholesterol is, what your HDL is, the good cholesterol, Are you a smoker? Do you have high blood pressure? Are you on high blood pressure medication? And then based on those numbers, it will spit out your risk for 10-year, how likely you are to have heart disease in 10 years. And again, we find the number 7.5%, if that's your risk or higher, we recommend you be on a cholesterol medication. All right, and so there's various types of medication that you can be on to help achieve good cholesterol. All right, the most common one are statins. All right, those are things like Prevestatin, Simvastatin, or Zocor, atorvastatin, or Lipitor, or Crestor. All right, and what we find is there's kind of a low dose, or we call it moderate intensity statin therapy, and a higher dose, a high intensity statin therapy. Crestor and Lipitor at the higher doses tend to offer the most protection. So people that have come in with a heart attack, have a stroke, we may put you on that high number. Or if you're not responding, your LDL is not coming down, that might be why we increase that. And what we find with the statins is that not only do they bring down your LDL, the bad cholesterol, we also find that they do something called stabilize the plaques, which is what I was mentioning earlier. When you have those cholesterol plaques in your blood vessels, and if you have high blood pressure or you're anemic, something that causes the blood to move faster, that can put a stress on your system, and it can actually cause part of that cholesterol to break off. And when it does that, that's when you can have a blood clot there, it can block off the artery, and you have a heart attack or you have a stroke, something bad happens. And we find that the statin medication can actually kind of keep the cholesterol, the cap, the outer coat in place so that doesn't happen. So it's another reason why not only does it prevent you from getting more plaques or building up plaques, it keeps the plaque stable so you don't have these kind of bad things happen. Another common medication that people use is niacin. I don't know if how many people here have used that. It is effective. It makes people really flushed, and so that kind of limits its use. There's something called fibrates, tricorlopid, gimfiprazole, fenofibrate. These are medications that are good to bring down your triglycerides. Usually it's not what we're going to start with if you have cholesterol plaquing, but it's a good option. And then let's see, this one here, Zetia. It's a cholesterol absorption inhibitor, and that's another medication that we like to add to statins, like Lipitor, atorvastatin, Crestor, Prevestatin. The Zetia helps prevent absorption of cholesterol. Again, the same concept of why you like to have a little more fiber in your diet. If you don't actually absorb it into your body, it just kind of goes out in the waste. That's good. And then omega-3 fatty acids are another way to help lower your triglycerides. So we'll just wrap up with some cholesterol tips. The first is maintaining a good weight and exercise. 30 minutes a day of eating the right foods. We want to ask you to quit smoking, keep your blood pressure under control, and help manage stress, get good sleep, take your medications. If you stop them, please let your doctor know. And then know your family history if you're at a little bit increased risk. And then also just follow your cholesterol so that you can keep it under control. So with that, if you guys have any questions. Yes.
I was told by a cardiologist that once plaque is in your arteries, there's nothing you can do that will ever make it go away. It will continue to build.
Actually, there's evidence coming out of, sorry, the question.
Would you repeat the question?
Sorry, yeah. Okay, so, sorry, I forgot, sorry. Okay, so the question is once you have a plaque, does it ever go away? And there's actually evidence through one of the labs down in Texas where if you do things like watch your diet, you exercise, you lose weight, you take cholesterol medication, there's evidence with like nuclear imaging that you can actually improve the blockages in your heart. So they can be reversed. So it's not like once it's there, you're lost. It can actually turn around. Again, that takes a lot. Good. It's going to be that medication, the lifestyle changes with exercise and diet, but it can be done. Any other questions?
If your HDL is too low, how do you raise it?
So the best way to raise your HDL is going to be through exercise and diet. So, a lot of times what we find, well, it's actually kind of cool. If you're in a weight loss program or you're losing weight, we can actually track your cholesterol, and the HDL will keep rising up. Some people, there are groups of people that, despite all of that, their HDL does remain low. But in general, we find good exercise and diet are probably the best way to bring that number up. So.
Have you heard of a calcium test that you can take?
Yes. So are you talking? The question is a calcium test. So one way to screen for heart disease is to do like a calcium score. I think is the CT scan. That's what you're thinking, or are you asking?
No, my sister-in-law has always had high cholesterol, can't take any of the medications, so they did this calcium test to see if she had blocked arteries, and she was fine.
Okay, I think what you're talking about is there's a calcium score where what you can do is, it's kind of like it's not a stress test, it's actually just imaging. So, okay, if you remember earlier, I said that you have the cholesterol that builds up, and it builds up with calcium, and so you can see these the blockages, the plaques on like X-ray imaging, so an X-ray or a CT scan. So one way to look for that is we can do a CT scan of your heart, where we're actually measuring how much calcium we can see in the blood vessels of the heart. And there's a calcium score, and that can tell us, if there's no calcium, well, that means that you don't have enough plaques that we're able to see it on the picture, and that's a good sign. Or if you have a lot of calcium, a very high number, then that's concerning that you've developed atherosclerotic disease. So what you do is you go into a CT scan, and then they look for that. And so.
What are your thoughts on the over-the-counter cholesterol lowering medications?
Okay, so those would be like niacin, I think, and the omega-3 fatty acids. Are there? What else are you thinking?
Cholesterol off or OQ or?
Oh, the coenzyme Q10.
Yeah.
The coenzyme Q10, I don't think in and of itself is going to significantly drop your cholesterol. What we have found, or what I found clinically, is that a lot of times people that are on statins, like Lipitor, Prevestatin, Simvastatin, Crestor, that they get the muscle aches and pains. Sometimes if you take that coenzyme Q10, it can help, about half of those, what I found, have those people get rid of that muscle cramping. Yeah. So there is some evidence for red rice yeast. So a lot of these, like the red rice yeast, there's just not the clinical trials. Like it's suggestive that it's helpful. I just, and maybe if you don't have any heart disease, it's probably okay to be on those. But I don't think that's I couldn't recommend, like if you had a heart attack, that you should just be on that. Okay, because it helps, but it's not, it just doesn't have the clinical trials that things like Lipitor do. Yeah.
What about the length of time you're on a statin? Should you ever go off it or try different ones to kind of?
So, okay, once you're on a statin, chances are once you're on a statin, you're probably going to stay on a statin. I hate to tell people that, but so depending on why you were put on a statin. So if it was because it was like a primary prevention, like perhaps you did the calculator and your risk was high, or you had your cholesterol screened at work and your LDL, the bad cholesterol, was high, but then that scared you and you made lifestyle changes and you were able to bring it down, that might be a situation where we could talk about stopping a statin. But oftentimes, if you've had a heart attack or you've had a stroke or there's a reason, we've seen a cholesterol buildup in your arteries, we'd keep you on a statin. Depending on how you respond, that's how we decide which one we'd keep you on or if we needed to change one. There's, according to these new guidelines that came out about 3 years ago, there's kind of a classification within the statin realm. There's this moderate intensity, which is good for prevention, and then there's the more aggressive, like you just came in because you had a heart attack. And so that might be why we might change. We might increase your cholesterol dose. Again, you know, it's depending on your lipid profile. Like we might have you on Lipitor 20, but your LDL is still high, or your triglycerides are higher than we like. We might increase you. Sometimes we also will switch statins if you had side effects. So sometimes people get leg cramps or the muscle aches and pains with one, and we'll just try another one, and some people do better with that. So, but yeah, if it's working, then I'd probably just keep going.
Are the generic medicines all right? Not
Yes.
the Lipitor, the generic
Yes,
ones
yes,
out
yes,
there.
yep. Atorvastatin is just as good as Lipitor. So and those are like the generic and the brand name. And Zocor is just fine like for simvastatin. So it's been nice that Lipitor is now generic, because then you can get good therapy and hopefully not break the bank. So.
Are there other side effects to taking a statin?
The
Besides the muscle pains and
That's the most common one. You know, I think a lot of people develop them. Usually, if they're going to have them, they go away within 2 weeks, definitely by a month. Sometimes it's just so debilitating that you have to cut back on the dose. You try every other day. You try a different one. But wait, so, what was the other part of the question?
what other side effects?
Oh, the other side effects. There are other side effects that are very rare, and I don't want to alarm, you know, people, but if you can have muscle aches and pains, that's one thing, but it can actually very, very, very rarely, most people don't get this, so I don't want to, yeah, this is very rare, it's very rare, but it is possible that people can have so much, like the muscle aches and pains are actually from real muscle breakdown, and so then people can get, muscle breakdown can lead to like kidney problems, because you're actually clearing out some of your muscle, and like your urine becomes like the color of Coca-Cola. So that's a problem. You should let someone know about that. But that's very, very rare, and it's also possible, but very, very rare, that you can have liver problems too. But there's a lot of people on statins, and that's, I don't.
In our family, it's genetics with the high cholesterol. Is it bad that he taking a higher dose of cholesterol medication? We've heard that that's getting
So, okay, I'm just going to repeat the question. Okay. So if you have like a familial hyperlipidemia or high cholesterol because of in your family, we would still recommend taking, you know, whatever dose you need to get your to get your lipids down, like your L.
But it seems like we have to keep taking a higher dose as years go on because we can't keep drinking now.
And that can happen. So.
But then we hear that that's not good for you to keep getting higher doses. So then what?
So in general, it's probably, you know, it's going to be a risk benefit. You know, if you are someone that has really high cholesterol in general, just because of your genetics, I think you're at increased risk. And so if you're tolerating your cholesterol medication, you're not having liver problems, you're not having muscle problems, you're not having kidney problems, I think your risk of having a stroke or a heart attack could be actually, you know, higher than the risk of a complication from the statin. And so that might be, you know, something you want to talk to your doctor more one-on-one about, but so, okay. All right. Any other questions? Oh, yeah.
I had a boyfriend who had a stroke at age 57, even though he had an active job doing construction. And then I have real high family background on both parents' side of heart trouble.
Okay.
And so it turned out he was on 20 milligrams of pravastatin a day, and I was on 60. Was that because his stroke was from a blood clot and not from cholesterol, or just because we have different doctors?
You know, without really actually knowing a little bit more about you and him, it's kind of hard. It's kind of hard to comment on that. But there's a lot of things, a lot of factors that, you know, can go into play with why people are on whatever dose. So. Yeah.
Besides family trees, do you feel that Shiftwork has a lot to do with heart disease?
I honestly don't know of any clinical trial that has said Shiftwork hurts your heart. There is data to suggest that more stress and like messed up sleep patterns could be stressful and could affect your heart. So I think there's some suggestion of that, but I don't think there's no hard or fast clinical trial, unfortunately, that says this is bad or this is okay. But just I think the inherent stress of shift work can be hard, and that is appreciated. So, yeah.
You said, like when you're reading labels, it should
Yeah.
be less than 7%. How much overall per day? Is there like a limit, or you're just looking for the label so that you know it's lower fat and better for you?
I would look at the label just to make sure that it's more of that the unsaturated, not the trans, or the saturated. I think the label can help. Without, like, everyone I think has a little bit different, like how much fat you need versus, and that one it might be better suited with like a nutritionist so that you can go through and look at where you need to be. Because if you're trying to lose weight, maybe you need less fat in your diet. Yeah, but.
Has the relationship between estrogen and cardiac changed? In other words, a cardiologist said I can't take estrogen. Gynecologist says you can't live without.
So that's actually kind of interesting. So there was
That's a problem for me.
There was this idea that okay, we see that women they're protected from heart disease up until menopause, and then very quickly they catch up to men. So shouldn't we just all be on estrogen until we die? And there was a clinical trial that looked at that and with that thinking behind it. And actually what they found is that there was more heart disease. We were not quite sure if that was just because maybe the extra estrogen made you more likely to have small blood clots, and that was how you were having more heart disease. But now in terms of like from cardiology's standpoint, if you need estrogen to kind of get you through like menopausal symptoms, that's one thing. I would not just put I'm not going to put all my women patients on estrogen because it's actually been shown to be harmful. And again, the exact mechanism I think we're still trying to understand, but the clinical trial that looked at that was not good for us. So, yeah. Say again?
What about adding foods with phytoestrogens to your diet instead, like soy?
Oh, I have to say, versus taking like a pill. I'd have to look into that in terms of how that's absorbed and gets affected. I just am not familiar with the literature on that one. I'm sorry. Yeah.
If you're allergic to the sugar in milk and you have to take a milk substitute, what is the best?
Like are you talking, if you're allergic to like.
Milk or
soy
milk or coconut milk?
And you can't just take a Lactate?
They say coconut is good for you.
Yeah, I don't think there's not been a clinical trial on that one either. I think you probably would be okay with any of those. I don't know if there's one better than the other. I just don't think there's enough data to be able to compare one versus the other. In terms of dairy, in general, what they've looked at is just the more low-fat, non-fat dairy. And they think that the calcium in dairy products may actually inhibit the absorption of fat from your GI tract. So that's kind of this, again, along the lines of fiber. If you never actually absorb it from after you've eaten it, that's one way of preventing cholesterol. But, Any other questions? These are good.
Can someone's cholesterol be too low?
Yeah.
And the reason I'm asking that, my husband had a heart attack when he was 50.
Oh.
And his cholesterol
cholesterol is very low. His total number is very low.
Mm-hmm. So,
I think he has a total of 100.
it kind of depends on the breakdown of what's in that 100. Because remember, you have your HDL, your LDL, and your triglycerides. And if most of that is the bad stuff for triglycerides, that might, I could see that being a problem. Now, there actually are like genetic conditions where you don't have cholesterol, so that's not good either, but, or like you're very low fat. But that usually doesn't lead to heart disease. So,
His LDL is like 42.
okay. And there might be other reasons behind what was going on, because without knowing where he was at when he had his heart attack, you know, it's hard to say. So, okay. Yeah.
I've read that people that have a high homocysteine level and low cholesterol can still have a heart attack.
Yeah. So, okay. So people with a high homocysteine level can still, with a low cholesterol, can have a heart attack, and that is one of those kind of genetic things that can predispose you to having a heart attack. And it's a different kind of inflammatory system or a mechanism versus like the actual, like more traditional getting cholesterol plaques and such that build up. So
They're going to stop because I'm up here.
okay.
You don't have to stop, ladies, if you have more questions.
More questions? Dying to know about cholesterol?
Sleep apnea. Any relation between sleep apnea and strokes?
Oh, sleep apnea. Okay. Sleep apnea. So that's this, we're finding more and more out about sleep apnea. And what that means is that when you sleep, you stop breathing. And it usually has to do, there's two kinds, a central kind that has to do with like really bad heart failure. And then there's also a peripheral kind. And that has to do with how the back of your throat is. So it's your anatomy. So just how you are. And when you sleep, you actually occlude the back of your throat, your airway. So you stop breathing. And so what happens, and that's bad. And so what happens when you stop breathing, you know, you send signals to your brain like you need to breathe. And so if you're in a very deep sleep, you move into a lighter sleep, you know, to wake up, to like tell yourself to breathe. And that's why if you have sleep apnea, you don't feel rested and you can fall asleep very easily. The other problem when you don't get oxygen to your body is it hurts your heart and it can hurt your lungs. In terms of your heart, you can have very difficult to control high blood pressure. And if you have heart failure, it's more difficult to control if you don't treat your sleep apnea. It can also lead to lung problems, something called pulmonary hypertension. And that's like, you know, you have high blood pressure in your arm, we have high blood pressure in your lungs. And that's actually very challenging to treat. And so it's much easier to prevent. And so that's why, you know, sleep apnea, there's been more and more awareness. And the way to find out if you have it is to do this wonderful thing called a sleep study, where you go to the hospital and they hook up all these things to your head and on your finger, and they watch you sleep because that's natural. And then they tell you if you have sleep apnea or not. And then if you do, you wear a really cute mask or something in your nose, and it opens up those airways so that you can actually breathe. And then you sleep wonderful and you feel like you have all this energy, and so it's a good thing. So.